Okay, so we are the Rasopathies Network, and we our mission is to advance, there it is, escape, crossing my screen, is to advance research to improve the quality of life for Rasopathies families by bringing together families, clinicians, and scientists. So this is one of those events. Next slide. So who we are. So I'm the president, and Lisa Schill is the vice president. Beth Stronach here is the secretary, and we have a treasurer, Bruce Beckman, and at large we have Lee Johnson, Elizabeth Parker, who I see here today, and Cara Borian, who might be here, but I don't see on the screen. All right. So if you go to our website, you can also find ways to reach us if you have any questions or interest. So is this my slide too, Lisa? Yes?
Yeah.
Okay. So the Rasopathies, the way we figured out how we're all related, you know, I think doctors kept on clinically confusing the Costello, the CFC, and Noonan diagnoses. Noonan, I remember going through it's like the possible male version of Turner syndrome is the way they first presented it to us back in '95 that we needed to rule out. And so when our researchers figured out the relationship was not actually by having genes next to each other that have a problem, but actually having the gene problems in terms of the function of the cell. That was a humongous shift and provided also an access to ideas and therapies, because this is a pathway that most third of all cancers have, and there's already researchers doing stuff to try to stop the signaling of the information from the cell, from outside the cell into the nucleus. But we just need to turn down the information so that just the right amount gets into our children's nuclei to tell the cell what to do. So that's been really exciting, because we also have strategies in the works right now that hopefully will help a number of our families that way. And in the meantime, we still have clinical issues. So this is the piece where people like Dr. Itkin is really important in helping us deal with the issues that we have at hand, that our syndromes make us more likely to have. Okay, so next slide.
That brings it to me, and I'm going to talk about, I'm Lisa Schill, I'm the vice president. I'm going to talk about one of the ways that we raise money for research. We just changed our tagline to connect, collaborate, and accelerate, because we're working on accelerating research. So one of the ways we do that is through the $1 Million Bike Ride. And this year, the $1 Million Bike Ride is virtual. It's going to be on June 12th. We raise money for international RASopathies research. And if we raise $20,000, which we've done for the last 7 years, the University of Pennsylvania will match that $20,000. So it's a really great opportunity to see your your donations matched for research. And here are a list of the different grants that we have funded. I'm excited to announce for last year, we funded the University of Western Australia for understanding RASopathies to better inform diagnosis and treatment. I know we originally talked about wanting that money to go towards adult research, but we have a group of PhDs who look at the grants, review the grants as they're turned in to see who we should fund, and none of them were really strong enough in the adult research section, unfortunately. So this turned out to be a really great research idea that will be funded, and you'll hear more about it in the future as it starts taking off. And in 2019, we funded Gregor Engelfinger, and he's actually going to be speaking at our scientific symposium. You'll hear a little bit more about our scientific symposium from Beth, but he'll be talking about MEK inhibition for RASopathies associated with hypertrophic cardiomyopathy. So we're really excited about that. So we've raised over $400,000 with this program. And then, I'm sorry, I'm just entering people into the room who are waiting. So how you can participate virtually. This year, everyone can participate. What is the cost? The registration to ride your bike, or you could walk, is $45. And if you raise funds, $25 if you commit to raising $250. And those are US dollars. You can create a giving page like this if you need any help. So you can, share your story with your friends and family to ask for donations. You could also just directly donate to our website and specifically say in your donation, I want this to go to the $1 Million Bike Ride. It's a really great opportunity, and I have my email here. I can walk you through setting up a donation page. So could Elizabeth Parker on our board. And it's just a great way to give back to the research community. And even your registration fees go towards the grant, which is pretty amazing. There's no overhead taken out. Penn covers all the overhead of the bike ride. So 100% of your money goes towards the grant. And I'm gonna stop sharing my screen now, because now we're gonna move on to Dr. Itkin. He's the professor of radiology and pediatrics at the University of Pennsylvania, where he's the director of the Center for Lymphatic Imaging and Interventions. And Dr. Itkin is nationally and internationally recognized for his clinical and research expertise in an interventional treatment of the lymphatic disorders. So I am going to give host to him. So if everyone can just patiently wait for a minute. I just gotta find them. Oh, there you are, Max. Okay. And now, take it away, Dr. Itkin.
Here we go. You can see it, right?
Yes.
Perfect. Thank you very much. It's a pleasure to be here on Sunday. I'm, as Lisa said, from University of Pennsylvania, and I actually participate in $1 Million Bike every year. Unfortunately, I go in with different team, Lymphatic Dermatosis and Gorham Disease Alliance, for many, many years. And this year, I probably participate, but that happened on June 12th, is that my partner in pediatric work in numerous hospital, she got married June 12th. So I probably will be there. It's Debbie Rabinovich. She's the head of the numerous interventional radiology, where I treat children. Adults, of course, I see in the University of Pennsylvania, children in numerous for the last 3 years. It's approximately 20-30 minute drive from Philadelphia into the Delaware. My background, I'm Russian originally, many years ago, 40 years ago. Then I became an Israeli. Most of my education I got in Israel. Then 20 years ago, I came to University of Pennsylvania to do fellowship in interventional radiology, and since then I'm there. And early on, I met amazing human being, one of my mentors, Dr. Kolb. He started to conceptualize the idea of lymphatic interventions and started to experiment with animals and first humans. And during this fellowship, I was exposed to that. I thought it's absolutely cool, science fiction. And then 20 years, I keep doing that. So this is my background. First, the most important thing to understand, what is the function of a lymphatic system? There's multiple immune transport of the cells, but the most important is removal of the fluid and proteins from the tissue back into the systemic circulation. So from capillaries, the fluid goes in the tissue, and then lymphatic system picks it up and has to deliver it back into venous circulation. And there's absolutely no venous reabsorption. So any edema in the body, any accumulation of the fluid, lymphatic system is responsible for that. So what are the lymphatic abnormalities? I'm terribly sorry, I probably pulled a wrong presentation. Give me 2 minutes, I'll just pull the right one. Sorry for that.
No worries. So yeah, so while he's pulling that up, I can just say, you know, with the $1 Million Bike Ride, that we're really trying to increase our reach and get more participants this year. So you can walk or run. You could just even create a giving page if you're not, you know, you don't want to be active and you just want to tell your story. So thank you, Elizabeth. Elizabeth just joined where you can join the team. Just make sure you pick the Rasopathies. But it's a really great event.
Lisa,
yeah.
I have to switch. I thought the presentation moved to my office computer. Give me 5 minutes. I have to go my laptop where I started.
All right. You know what? Can you switch the host back to me, and then we'll just talk about the symposium while we're waiting?
Yeah.
Perfect. Awesome. Okay. Thank you. So we're going to jump back now. We had a few other things we were going to talk to you after Dr. Itkin spoke, but we can actually talk about them while he is finding the presentation. So let me share my screen. And let me introduce you to Beth, but I have to unmute her. There we go, Beth. Can you hear me?
Yeah, okay. Awesome. Come on. Thanks, Lisa. I was thinking, oh no, how am I going to communicate that I can't unmute myself? But anyway, here I am. I'm Beth Stronach. Nice to see all of you, both old and new visitors to our webinar. I wanted to just tell you briefly about we have a contact registry. We don't currently have a sort of patient registry where we're collecting medical data and things like that. But we do have a contact registry, which we use essentially to collect your name and your contact information so that we can, you know, is that Max? Contact you to basically keep you abreast of research studies or other relevant information for you to be able to find out about research that's going on in the community or surveys that are going on. We collect enough information so that we can try to tailor an email to you saying we think you might want to participate in this one. Let's say it's specific to Noonan syndrome or specific to CFC or something. So anyway, if you're interested in being part of our contact information, you can email the website at info@rasopathiesnet.org, which is shown on this slide. We typically like to collect information about the person that's affected with a RASopathy, and you can see those things there in the left-hand column, and also the simple contact information for the primary caregiver and also a secondary caregiver, so that over time, you know, if people's email address changes, then we'll be able to still contact you through the other caregiver. So we're trying to build this up in anticipation of new things coming down the line, including a natural history study that's going to be started hopefully this year through the National Institutes of Health. So if you might be interested in participating in research studies or surveys, please send us an email at that address or at Lisa Schull's address, and we'll reply with an email where we can get that information from you. Thank you.
And it looks like Dr. Itkin is back. So I'm going to switch back to him, and then Beth, you can talk to the symposium after.
Sure.
So let me, oh, make him the host. Well, let me stop the share. All these fun, make host. Yes. All right. Take away, Dr. Itkin.
Just 1 second, almost there. Yeah, I'm sorry, all my computers supposed to synchronize, and it looks like server went down, and whatever version I created my laptop, that didn't come to my main computer, but I'm with laptop right now. So so what are the lymphatic disorders? First, the most known one is lymphedema, because we can see it. So everybody will talk about lymphatic disorders. Everybody think about swollen lymph nodes in the neck or lymphedema. The second one that's known is lymphatic leakages. For example, lymphorrhea. Lymphorrhea can be scrotal or genital lymphorrhea or skin lymphorrhea. As a matter of fact, it's a leakage of fluid from the surface of the body. Chylothorax, of course, chylosascites, chyluria, and protein-losing enteropathy. The last one relatively difficult to determine, but pretty much anybody with low albumin would consider or evaluate this patient for the protein-losing enteropathy. So what's interesting, over the last probably 10 years, I see Noonan patients, and I primarily see Noonan. I almost was only one Costello patient, but all my patients were Noonan. What uniformly all patients that come to me with lymphatic problems, Noonan patients, they have increased lymphatic flow. And we don't know why it's happening, but it's clearly observation that I made over years. And what does it mean? You can see here, I'm doing this lymphangiography. I inject contrast through the lymph nodes, and immediately can see that there is a very, very fast flow of the lymph from the groin toward the central lymphatic system. Usually, you never see it's going that fast. We see it in Noonan. Occasionally, we see it in other disorders. For example, Klippel-Trenaunay, or sometimes it's completely idiopathic. So what does it mean? That means that the lymphatic system is overstretched. There's too much lymphatic flow going through that, and it's caused what's called lymphangiectasia. Also, uniformly in all patients, what we see with lymphatic disorder in Noonan, we observe some type of lymphatic obstruction. And you can imagine if you have too much lymphatic flow occurs in the body, and then you put a dam somewhere, this flow of the fluid try to find the way out. So what happened is something that called lymphatic reflux, happened, and this lymphatic reflux caused symptoms. If the reflux occurs to the genitalia, skin, it will be again lymphorrhea. And if it's go into the pleural cavity, it's chylothorax, abdominal cavity, chylosascites, chyluria, and if it's going in the intestine, it will be protein-losing enteropathy. And this is just an example, schematic representation of how it's happened. So this is the chylothorax. So if there's a properly narrowing at the thoracic duct, you can see this is a thoracic duct in the middle of the chest. It collects most of the fluid from the abdomen and carries approximately 90% of the body lymph. And then there's some type of obstruction and narrowing at the end, and fluid reflux into the lung parenchyma, causing chylothorax. So why it's become very relevant, all this observation now? Because we, over the last 20 years, I and many of my partners developed new lymphatic imaging techniques, such as a intranodal lymphangiography and magnetic resonance MR lymphangiography. I will talk about them today. And also there's a new entities as mesenteric lymphangiography and liver lymphangiography. Mesenteric is supposed to show you the intestinal lymphatics, and liver, of course, liver lymphatics. So let's start with intranodal lymphangiography. It's a very, very simple technique. Using ultrasound guidance, physician will identify the lymph node in the groin most of the time and put a small needle into the lymph node and inject dye. And that's how it looks on the patient. Here's the head. Here are the legs. You see this is a hand here. So both groins have the small needles. It's a very, very, very small needle, 25 gauge. We actually even don't give a local anesthesia because local anesthesia is more painful than this needle. And then on the left, you can see there's an immediate opacification of the lymphatic system. What does it do, this technique? Why it's actually made a revolution in my world? Because it's very simple technically. Almost everybody in the world that knows how to hold ultrasound probe and needle can do that. One of the most important thing is actually cut down the procedure time. When I started with Dr. Kopp, we used to do pedal lymphangiography, where we cut the small lymphatics in the foot and cannulate them and inject contrast. It took sometimes 9 hours to do procedure. Right now, with this technique and with some modification, I can finish within half an hour basic procedures such as thoracic duct embolization, maybe 40 minutes, but no more than that. So then we said, okay, we can inject lymph nodes with contrast. It's usually a contrast what we use is oily X-ray contrast. But if we inject the gadolinium, can we see something in MRI? There was certain technical problems with that because you cannot put ultrasound machine inside the MRI. So it took us a few years to figure it out. Fortunately, right now, most of the MRI scanners comes with detachable machine. You can take it out of MR suit, put outside the MR suit, and use ultrasound and inject, put a needle into lymph nodes. And on the right, we developed a technique where we actually confirm the position of the lymph nodes with ultrasound contrast. You see, this is white star. This is actually ultrasound contrast in the afferent lymphatics. And that's typical of the picture we got. This is normal thoracic duct. We have probably 20 patients by now that have a normal thoracic duct. Some of them we enroll as a part of the research trial. So they're absolutely normal. And some of them come in for other diseases and we don't see any abnormalities, so we consider that normal. But that's how it's supposed to look most of the time. You can see one beautiful thoracic duct goes from the abdomen all the way up to the neck. And here at the top, it's actually discharge of all this lymph into the venous circulation. And this is abnormal. You can see that there's not only one thoracic duct, but maybe there are multiple other ducts that come in from the thoracic duct, and actually they feed the lung in this patient with scalothorax. What we often see in Noonan is isolated neonatal calothorax. As a matter of fact, when patients refer to us with neonatal calothorax, the first thing we will do is we will send the genetic panel, and most of the time the genetic panel comes as a Noonan syndrome. So again, what we see here is instead of one beautiful duct, there's a multiple ducts that supply the lung and causing calothorax. So what kind of tools we have to treat these disorders? And sometimes we call it lymphatic flow disorders because it's essentially lymphatic flow. Essentially we're plumbers, as anybody else, as interventional cardiologists or vascular surgeons, or even cardiac surgeons. So we can glue these abnormal lymphatic pathways or embolize them. We can embolize with contrast material, lipoidal, Why we can do it? Because Lapidol is a very thick oil. So all neonates that have come to us with isolated cholothorax, we just inject 1 cc of Lapidol and immediately cures their problem. We can embolize thoracic duct, and also we can do interstitial embolization, where we put a needle into lymph node and inject glue through the lymph node. The last one actually become the most important technique that we use right now, because it allows us do procedures on very, very small lymphatic vessels. And relatively new comment to our world, maybe 5-6 years, surgical lymphovenous anastomosis, but also we can do percutaneous angioplasty of certain lymphatic structures, and I will show you. So this is Lapidol injection. It is the same key that you saw before. Abnormal flow from the thoracic duct into lung parenchyma. And here we inject Lapidol. Lapidol, again, it's a contrast. I see it's coming from below and goes into the lung parenchyma. And because of its contrast, you can see that. And again, it's the simplest procedure we do. We just inject 0.5 cc and 0.5 cc both sides in the groins of his material, and kids immediately within 2-3 days got better. Sometimes the cases could be very complicated, like in this one, where there's absolutely no thoracic duct. And again, there's a reflux from the stump of the thoracic duct into the lung parenchyma. As you can see here, there's again these two components of every lymphatic disorder. There's obstruction of the thoracic duct, or absence of a distal part thoracic duct, or complete absence of a thoracic duct, and increased lymphatic flow. So thoracic duct catheterization we use quite often to define better thoracic duct anatomy. How we do that? We take a very, very small needle. First, we do intranodal lymphangiography, and we can see this, what's called cisterna cali, beginning of the thoracic duct. Then we'll take a very small needle, advance it under ultrasound guidance, under X-ray guidance, sorry, and put a wire into this cisterna cali and thoracic duct. You can see here needle, and in a second I will put my wire out, and it goes inside the thoracic duct. Whenever you have a wire inside the thoracic duct, you can put a catheter and inject dye. And here how it looks. This is normal thoracic duct. This is one of our research patients, so no problem. So I can tell you 100% it's normal. But the problem with a lymphatic system, there's so many variants, so many different deviation of the normal. So it's very, very hard to define what's normal, but this is normal. So, this technique we use, for example, on this patient, 60-year-old Noonan with severe pulmonary dysfunction. He actually didn't know that he has a Noonan until age probably 50, 55, when they discovered some dilation of pulmonary artery, and then he diagnosed with Noonan and was very, very functional, doing high-tech job servicing the some kind of secret planes in Maine. But in one day, he got pneumonia, and the central catheter was placed into his vein. And immediately after, he developed such a severe pulmonary dysfunction that he even couldn't walk 10 feet without stopping. So here we do our MR lymphangiography. It's hard to see, but you can appreciate this is thoracic duct, normal, but suddenly we see this multiple collaterals that go into lung parenchyma. And on the right side, again, MRI, but this time this MRI shows you how much water he has. So all white stuff, it's water. It's all abnormal. You're not supposed to have all this water in the chest. So we catheterize thoracic duct, as I explained you before. First, of course, we do lymphangiography, internal lymphangiography. And again, you can see how fast his lymphatic flow in the groin. So he's, again, this typical Noonan fast lymphatic flow. And then we inject contrast in thoracic duct from the catheter that's located here. And as you can see, there's total obstruction of the thoracic duct. So what can we do with that? We can do surgery. I work with very, very talented microvascular surgeons, Dr. Steve Kovich and Dr. Levine. And what they do, they take this abnormal duct that does not drain into vein and suture it back to the vein. And we're doing it combined procedure in what's called hybrid OR, where the big X-ray machine and OR together. So I put the catheter inside the thoracic duct, inject contrast to guide him through the procedure. And then he does this surgery. It's a microsurgery. For patient, it's very, very simple because it's just small cut on the neck. For surgeon, it's very, very complex. And here he's doing that. And this is a result after the surgery. This is anastomosis here, and this is actually vein. It's not thoracic duct as on the left, but it's a vein. So within 3 days, this patient managed to start walking, and within a week, he was almost normal. And we saw him 3 months later in the clinic and performed MR lymphangiography. All his symptoms completely disappeared, and you can see that amount of this abnormal flow that coming from the thoracic duct decreased significantly. And I believe right now we are 2 or 3 years follow-up after that, and he's doing phenomenally well. It actually accepted as a case report in one of the surgical journals. But interesting enough, we did surgery at the beginning because I did not know if we can do angioplasty of the thoracic duct, and we actually can. And this is one of our cases of thoracic duct angioplasty. It's not Noonan patient. It's a new disease that we discovered recently that comprise of severe abdominal pain and bloating, chronic, for 10, 15, 20 years, some people 2 years. But people have this severe abdominal pain, and the reason for this abdominal pain is obstruction of the thoracic duct. You can see that there's absolutely no flow through the thoracic duct into the vein on the left. On the right, we managed to pass a wire through this obstruction, and the next thing, sorry, because I'm host, I have to admit the patient, admit the people. So it's constantly clicking on admitting. It's great. People want to hear that. I love it. So anyhow, so you can see here is a balloon, and on the right, after we open the thoracic duct, there's a free flow, and all symptoms disappeared. So again, it's a relatively new condition. We didn't see it in Noonan, but I can imagine that this disease can happen in Noonan patients. So this is another demonstration of this abnormal lymphatic flow and obstruction. This is a patient with Noonan syndrome, of course, and severe bilateral lower extremity edema and scrotal lymphedema, and more importantly, scrotal lymphorrhea. So it's a very debilitating disorder, vaginal lymphorrhea and scrotal lymphorrhea. People can leak liters a day, and it's just extraordinarily uncomfortable. What's interesting here, you can see on the left is MRI. There's definitely a lot of lymphatic ducts here, but on the right is much more. Why it's much more? Because we ask patient to walk between left and right, pretty much stand up. And you can see that all this contrast that been accumulated in the abdomen right now reflux back down into the scrotum, into the legs. And that explains the patient's symptoms. There is a certain lymphatic obstruction at the top and too much production of the lymphatic. And you can see the lymph flowing from the abdomen down to the scrotum and down to the legs. So I saw this condition happen sometimes in people leaking a lymph from the toe. So it's actually coming from the abdomen, lymph traveling all the way down to the toe. Can we treat it? Absolutely. So there's 2 ways to do it: to do microsurgery to connect lymphatic ducts, or we can actually embolize this abnormal, close this abnormal lymphatics that goes to the scrotum, and treat primarily scrotal lymphorrhea and a little bit scrotal edema, but of course not lymphedema, because lymphedema requires not embolization, not closure, but opening. So this patient, and this patient specifically, we embolized, and his scrotal edema got better. Scrotal lymphorrhea improved significantly, but and was enough for this patient. But if we talk about patients that have lymphedema, of course, embolization is not going to work unless it's completely always lymphatic fluid coming from the abdomen down to the leg. So potentially we can close that. Lymphovenous anastomosis is most important. And this is how we do it. We put a needle into lymph node. Again, you can see absolutely crazy lymphatic flow in this patient. And here we inject glue. And you can see my finger here, because actually compressing the lymphatics, not to allow glue to go up, but direct towards scrotum. And the results was pretty good. So I think that lymphatic disorders are much more common in Noonan patients when we suspect. There are new imaging and interventional modalities that we can definitely understand and help to this patient. Who would consider for lymphatic imaging? Of course, callosositis, calothorax, but also unexplained shortness of breath, because we saw that a lot of people reflux their lymph into the lung parenchyma, and that can cause shortness of breath. The same goes with chronic productive cough or unexplained interstitial lung disease. By all means, I didn't see it in Noonan's, but there's other condition, lymphatic condition, where we can see this abnormal flow. Protein-losing enteropathy, we became very, very, very good with that. So, I said not very good, much better than 2 years ago, because we have new modalities to treat that. How do you diagnose this protein-losing enteropathy? Low level of the blood albumin, edema, of course. Lower extremity edema, we usually don't treat that many by myself, but I refer to my surgical partners who do this lymphovenous anastomosis, but we actually working and providing imaging to them before we do surgery, and of course scrotal edema, and generally everything you can explain sometimes can be explained by lymphatic system. So there is some, that's how we discover, that's how we go outside, and we when somebody in my institution asking what patient should we send to you, and I say always spiel, low albumin, leakages, but then at the end I will always add, and something you have no idea what is going on, talk to us, maybe we'll have some solution. We little bit in touch with NIH, trying to introduce these imaging techniques for lymphatic, to image lymphatic system in Noonan patient, to understand the changes in the lymphatic system, number one, and number two, identify some issues, some problem in patients that probably even don't know that they have this lymphatic problem. So anyhow, thank you very much, and I will try to answer the questions if we have any. Lisa, should I give you control?
Yeah, if you want to give me control, and then you can still, I can either read the questions, or if that.
Maybe you'll read the questions. So let me
Okay.
see. Well, I can actually do it. Make a host. Okay, good. Can you discuss what calothorax and pleural effusion are, and what the difference between the two conditions? So calothorax is one of the pleural effusions. There's a multiple pleural effusions out there, but calothorax is one of them. It's a leakage of the chyle, that is intestinal lymph, that originates in the abdomen and transferred from the abdomen by the thoracic duct into vein, but on the way through the mediastinum, through the chest, this thoracic duct can be injured, and the leak can happen. Your patient mostly have Noonan rather than other RASopathies syndrome, but do you know the incidence of lymph problems in Noonan? Are they rare, moderate, or common? Before I give a talk, I actually look in the literature, and the only thing I can find is multiple case report and small case series. We truly don't know. And that's the reason we came to the NIH and asked them to be part of their longitudinal study, where I think they follow 1,000 Noonan patients. Because of COVID, everything, of course, on hold. But hopefully they will, and we started negotiating back to them with them, and there's a few emails exchanged. So the next step for us to go and present all our data. Next question: are all swelling, including feet, ankles, and legs, possibly Noonan-related complication of this type? Yes. You probably talking lymphedema, right? So I am absolutely sure that there is a certain element of obstruction in all Noonan lymphedema patients. So there's another entity where the lymphatic ducts are not present in some cases of congenital lymphedema. Again, unfortunately, we did not see yet lymphedema Noonan patient, primarily because I'm trying to stay away from lymphedema. But understanding now that there are certain situations we actually can help in patient with lymphedema. We right now started to bring more and more lymphedema patient. And also I have a very good partners over the last 3 years that treat lymphedema. So I'm not refusing to see lymphedema patients any longer, but I have not seen, I have only 2 patients, 2 known patients with lymphedema, and it was clearly obstruction, overproduction, and reflux that were the cause of lymphedema. I'm wondering if there are any early markers of non-invasive tests for diagnosis of lymphatic issues in the gut for significant feeding issues intolerance. The only thing what we clearly treat and understand from lymphatic perspective at this moment in the gut, there's 2 actually. Number 1, protein-losing enteropathy, where is the leakage of the lymphatic fluid in the gut. It's relatively easy to diagnose based on the level of the albumin in blood. If it's low, you have to suspect it's lymphedema. It's protein-losing enteropathy. And if it's, and the second test is a stool test for something that's called alpha-1 antitrypsin. And if it's elevated, we know 100% this patient has a protein-losing enteropathy. The second condition I mentioned a bit earlier, the obstruction of the thoracic duct and that result in bloating, food intolerance, and severe abdominal pain. So by now we did probably 14 patients. We didn't publish it yet, but somehow people find us in comments. So we're preparing a manuscript to announce it to the world that it's a new condition, that we can easily treat that. But I can imagine that some Noonan patients have it. So the only interesting thing is that in all this patient I have with obstruction of the thoracic duct and severe abdominal pain, they are all female. Absolutely none of them were male. I'm not sure why, but generally lymphatic disorders are more dominant in white female, less than primary. Most of the patients we see it's a white female. Have you treated enough to start to know which variants are susceptible? No, probably not. We probably by now did 30 patients with Noonan, and that's how I build my picture of Noonan. But I cannot tell. It's too early, and we need to collaborate with definitely. And this is the reason why I'm going to present, and hopefully we can collaborate with genetics people, and of course numerous has a Karen Greek that she's amazing, RASopathy genetics expert, and I also work very close with London, St. George's Hospital in London, Sahar Mansour. So we probably need to collaborate more, and that's the reason why we went to the NIH, because we need more patients to come to us and start to learn more and more. My son had pain in the groin, which we constantly ruled out urinary tract infection. He also had enlarged scrotum. I wonder he might have an edema that causing pain. He has Costello's syndrome. A number of children with Costello's syndrome has a calothorax. By all means, any scrotal edema, I would think we can help to identify the problem at least, but probably also treat. Does it give treatment? So that if there is a treatment for this abnormal pulmonary lymphatic perfusion syndrome, yes, we can glue the abnormal lymphatics in the lungs. We actually have a big paper accepted right now in one of the pulmonary journals where we will discuss. We pretty much can control calothorax, non-traumatic calothorax, in almost 100% of patients. So we are very, very, very good treatment of calothorax. We're not very good with callositis, but we're getting better. But callositis is extraordinarily complex problem, but again, we're getting better and better because we have a lot of patients. So you can redirect the flow of lymph if the thoracic duct is small or misformed, and would this alone help in the accumulation of chyle in the pleural cavity? My daughter currently has pleural effusion, has been treated and CHOP before, and has had intervention, but not to the thoracic duct, which is not normal in her. Again, we can treat any callothorax. I'm not sure what kind of treatment was done at CHOP. I mean, if it's during the last 3 years, it's not me, but if it's 3 years ago, I was CHOP, so maybe I took care of her. But you have to contact us, and I can figure out. If someone had a lymphangiogram to treat absent thoracic duct, do they ever have to return to be treated again later on in life? Not. Most of the people doing very, very well. We just follow up. I believe out of 300 or 400, we managed to, over years, we managed to get in touch with 60 patients, call them back, and pretty much all of them doing extraordinarily well. There's occasionally a recurrence. For example, I treat right now a patient who has, we treated callothorax, and she was fine until she has a big car accident, and after that she developed another callothorax. So she's coming back for treatment, but generally this embolization treatment is very, very good and durable. In Costello syndrome, the acute chubbiness continue past infancy. I wonder if that is also lymphedema issue. Can you tell me what's acute chubbiness is? Swelling of the neck, or Lisa?
Oh, it's Lisa Schroyer. Let me just
Lisa, you asked. Yeah.
I have to find her to
That's it.
yeah, here, let me unmute her so she can ask.
Hi, thanks. Overall, they look like, you know, a 5-year-old can look like a 9-month-old, you know, chubby, fatty around the wrists, even definitely the cheeks, the torso, just kind of overall. And you know, everyone thinks they're cute, so, and they don't seem to complain. Well, they do complain a lot about all sorts of things, and we always thought it was the GI issue only, right? Because that's the classic search. But maybe we should rule out a lymph system.
So I can see how it's connected, but of course I have no idea. I don't know.
Okay.
But I can absolutely see how it's connected, because again, everything that's swollen of the tissues, it's all lymphatics. Yeah, but I will be happy to look into that if we have next acute.
Karen will have a lot. So Karen Grove.
Do you think that your imaging could be used as an endpoint in clinical trials with future drugs for treating lymphopenia in Noonan syndrome. We actually talking about that with LGDA, lymphangiomatosis kids, because they get sirolimus treatment, and right now MEK inhibitors, of course, the main expert in this oncological / lymphatic malformation field, Denise Adams, complains that we don't have imaging to understand how we actually affect the lymphatic system. We're discussing that to do that, to do as this procedure as a follow-up after the treatment, by all means, because it can show you lymphatic changes. It's a little bit involved because it's not just CAT scan. We have to put a tiny needle into lymph nodes and inject, but in children, anyhow, it's done under general anesthesia. And again, that's what we talking with NIH to start doing this procedure routinely, the imaging routinely, to understand the extent of lymphatic abnormalities in this patient. I'm a middle-aged woman with Noonan syndrome. I wonder if swelling in my legs are simply age-related or perimenopausal. I cannot, of course, comment on that. I have no idea. It's can be part of this lymphatic obstruction, by all means, but unfortunately, I couldn't comment on that. Is there a correlation to high triglycerides and possible lymphatic issue in Noonan syndrome? I assume high triglycerides level in blood. I don't know. I don't know answer to that. My 5-year-old son, Noonan, has uncharacteristic lung disease and few heart conditions. Talk of lymphatic issues since birth. He was now developed what has been described as penile edema. Will be eligible for lymphatic imaging and treatment. He seems to tick a lot of your symptoms. Yes, absolutely. By all means. I think we definitely can identify the reason for all the symptoms, but can potentially provide some treatment. If we notice sign of lower extremity lymphedema, should we seek treatment? That's again, it depends how bad is lymphedema, right? There's, unfortunately, for lymphedema, there's only a few options. Physiotherapy, that's the most common option, and recently lymphovenous anastomosis, where the surgeons create the connection between lymphatic vessels and veins. It's microsurgery. It's become more and more popular in the US. It's very prevalent in Asia and Europe. And I happens to work one of the best plastic surgeons in the world, who are also very, very, very interesting to do lymphedema treatment. This is Dr. Steve College. He's the one that transplant hands with bilateral hand transplant. Last week he was in Switzerland transplanting hands, but he's excellent microsurgeon. And originally I didn't believe that much in this lymphovenous anastomosis, because kind of very, very small, and you expect it to clog almost immediately. And to my absolutely amazement and delight, it's turned out it's extraordinary patent connections. I actually have one patient that came to me 5 years after somebody did lymphovenous anastomosis to her, and it was unrelated to whatever she came to me, but I have to image her, and I saw that lymphovenous anastomosis, even 5 years later, was patent. So it's very, very, very good treatment and provide good relief for the patient. In KFC syndrome, MSS or mucus frequently is pretty common. The amount of mucus for my daughter, about 1 to 2 cups, couple of times a day. The volume often shocks medical professionals. I wanted to explore the issue being to lymphatic. So yes, there's a condition. There's 2 conditions that we treat very, very successfully. One of them called plastic bronchitis. The other one called caloptesis, and it's a leakage of the lymph in the lung. So plastic bronchitis usually have to come with a cast. Just a mucus, probably not good enough. In some people, they can have this chyloptysis. Usually it's quite difficult disease in the sense that kids or adults suffocate because it's like their lungs overflow with fluid. So it's possible that your daughter has one of these abnormal lymphatics flowing into lung parenchyma, but I'm not sure 100%. We have also few patients that coughed enormous amounts of mucus, and we thought that they have some type of lymphatic leak, and it was negative. So again, the only way to know is to do MR lymphangiography and be for sure. And of course, just start talking to us. And there's also signs on CAT scan that I know that are signs of the lymphatic leak. So if the CAT scan is absolutely negative, I would doubt that there's a lymphatic leak. Have you ever heard the medication mechanism to help to rework the lymphatic on Noonan child with scrotum and lymphatic leaking and swelling? Of course, MEK inhibitors as a new popular treatment, and it works for sure. But I never heard, it's still at the level of the case reports, I believe. Lisa's probably know more than I about that, how much mechanism is used right now. I can see that scrotum can be treated. Scrotum lymphatic leakage can treat it. The problem with mechanism, it's a quite hard drug, right? So we all, and this is another question I've been asked many times. Where do interventions versus medications, right? And in reality, if you can fix mechanically something that's leaking and that's it, why should you go on hard medications? Why would you have because both sirolimus and mechanism, they all have complications. It's difficult to medications, besides the fact that they're super expensive, right? So, but if I can inject 2 or 3 drops of glue and stop the leakage, and child or adult don't need to have this treatment, why not, right? And that's where we kind of discussion, not from Noonan, we have much more patients that with similar clinical presentation, lymphangiomatosis kids, because when we have our meetings, we always discuss it, and the consensus, yes, if you can treat mechanically, do that. Would you recommend lymph massage with Noonan due to the overproduction of lymph, misformed thoracic duct, and no place for the lymph to go, so drain into lungs? It's a very specific question. I don't know. I don't know what to answer. Again, the best way is just image the lymphatic system, understand what's going on, and come with a plan. You said you work with St. George's in London. Do you know if you're doing these tests and procedures too? Yes, I was there 2 years ago in St. Thomas, St. George's in London, and did, I believe, 10 cases, and also MR lymphangiography. And I know that they started to do that for sure, because they send me images, ask me questions. The interventional radiologist that does it, her name is Lakshmi, I forgot the last name. And the genetics person that kind of overseeing the whole process is Sahar Mansour. If a person has Noonan, NSML, what NSML is Noonan?
Noonan syndrome with multiple litiginees.
I see.
So formerly leopard, yeah.
Right. Sorry, I'm not expert in Noonan, so some terminology I probably don't know. Unfortunately, in my job, I have to be neonatologist, GI doctor, cardiology with the cardiology, pulmonary, and what else? Right now, infection. We started with infection, HIV. So I'm jack of all trades, and I know a little bit about everything. But sometimes I couldn't get too deep. So anyhow, so it's Noonan, right? Pretty much. If a person has a Noonan and primary lymphedema, if there is a high percentage that as a person of ages, they should be more concerned about lung problems. I don't know. I don't know answer this question. That's did I see people that present to me old Noonans with calothorax? Absolutely, especially after surgery, because often the Noonan patient have a surgery, right, because of cardiac problems. I saw at least 3 or 4 patients in their 50s, 60s. Noonan had a pretty bad calothorax after the surgery, and of course, I mean, we treated successfully, but it was not easy cases to do. It was a few years ago. I have not seen recently calothorax after surgery in adult 50-60-year-old patient. Is there anyone in Canada who's experienced doing embolization in the groin area? Not sure. I know that one doctor there does thoracic duct access and embolization for traumatic. It's Diraj Rajan. He's the head of University of Toronto interventional radiologist. He was 2 years fellow before me, so we're kind of friends for many years. I know he does a little bit of this type of work, but I'm not sure about groins. I never see any publication, and nobody ever talked to me about that. Have you looked in the immune system in this patient? Do they have fully functioning immune system? No, I didn't. So I actually worked very close with Immune Institute at Penn. We sample the lymphatic fluids for research purposes, and the samples over the last 4 years create a new, how would I say, not field of medicine, but a lot of research. Because we send the fluid, we pack it in small pieces and send everywhere in the world. And we literally have papers in Cell, GCI, Nature, Immunology, and right now Science paper coming out, because nobody ever done that. So of course, if you have a material that nobody ever used, so of course some big science coming out of that. So again, we probably send some of the Noonan patients to this group, fluid from Noonan patients to this group, but I'm sure we just did general immune research, but not clinical immune research. So I don't have an answer. I think it's the last question. Oh, sorry. Yeah, after my son, it's Florida. After my son had surgery, he developed pericardial pleural effusion, was scared his surgeon and cardiologist. Yeah, it's just to reinform that cardiac surgery can cause calothorax, right? So the problem is that we figure out, especially on the pediatric cardiac surgery, and I think we published it in Circulation, that the people has this abnormal lymphatic ducts, main thoracic duct, but also develop this abnormal lymphatic connections, lymphatic collaterals in the chest. And we don't know why they develop. A lot of time they're actually normal. I see that in normal people. And because in surgery, thoracic duct lives on the back of the chest, whereas all these small lymphatics, they are actually at the front. So where cardiac surgery happens. And that's a reason why they injure these lymphatics. And unfortunately, embolization of the thoracic duct can absolutely clearly help this patient. If there is a particular sort of cough associated with calothorax, and if some has a persisting cough, lasting months with short clear periods over the course of years, and no other systems, should calothorax be considered? It's not calothorax. Calothorax, it's leakage of the lymph in the chest cavity. What you're talking here are more about lymphatic leak into bronchi. Again, it's absolutely possible that some people leak a lymph in the lung and cause them persistent cough. Usually, it has to come with certain color. It's kind of whitish. Number one. Number two, it's often comes with a lymphatic casts, and lymphatic casts, bronchial casts. It looks like a bronchial tree. If you Google it, you will see thousands of pictures of this cast. So again, the only way to know, do MR lymphangiography and see. That was the last question.
Yes. Well, thank you, Dr. Itkin, for taking time on your Sunday to be here with us today to describe everything. And we're excited to learn more. And hopefully, you know, when the National Cancer Institute and the NIH's natural history study comes out, we'll be hearing even more from you.
Very good. Hopefully we'll be part of that, because it was planned a year ago, and right now it's COVID again. It changed everything, right?
Yeah. Well, we should be making some announcements soon, hopefully, crossing our fingers, right? So.
Thanks a lot, Lisa, for the invitation. And any questions? Lisa, please feel free to share my information, my emails, and I'll be happy to help as much as I can.
Yeah, so we're recording today. So once we send out the recording to everyone who registered, we'll also send out Dr. Itkin's contact information for everyone.
Very good.
And thank you. And then we also still have Beth. I know she just talked a little bit about our registry. So we have been working with the National Cancer Institute on a longitudinal natural history study. And when that gets, it's been in the process, but when it starts collecting patients, we want you to be able to find out about it right away. So that's one of the reasons for joining our registry, is so when we have research opportunities like that, we can send you an email and say, hey, this study's open. If you're interested, please contact them. So just email us at info@RasopathiesNet.org if you're interested. And now I'm going to unmute Beth so she can talk a little bit about our scientific symposium that's also coming up this summer. So let me share my screen. I gotta, are you unmuted, Beth?
Okay.
Yeah.
Thanks, Lisa. Boy, that was a really awesome presentation from Dr. Itkin. I learned so much. I've heard some of these words before, but never knew what they meant. So that was fantastic. And we're excited because he's actually going to present at our symposium that's coming up as well. So he may even have more information by that time. So I just wanted to remind everybody, we were scheduled to host an in-person meeting this summer. However, because of all the stuff going on, we had to make the decision to go virtual. But we want to remind you that the dates are July 23rd through 25th. So this is a Friday, Saturday, and Sunday. We're going to hold our virtual meeting. The registration will be up soon. It's not quite there yet, but you can find information about it on our website. And we have both deep science talks as well as some panels where we bring together clinicians and researchers and patients, families. So we love to have the voice of the individuals that have RASopathies to attend the meeting, and it's potentially easier this year because you don't have to travel. So what are the opportunities for you to share at the meeting? We've in the past, something that's been really well received has been that we've had several families present posters. So you can see that highlighted in the pictures on the right-hand side there. It's a way of presenting information to the attendees of the symposium and to interact with doctors and researchers outside of the clinics. So you can just have social conversations with them, and you can tell people what your story is and what you need and what you hope, and what your quality of life is and what your struggles are. And so this year we're going to have some families present short poster presentations, probably just a few slides, since this is this virtual format. But I think basically if you're interested in doing that, you might also shoot us a line that you might be willing to participate and share your story. So we hope that you'll be able to attend. At the end of the virtual symposium, we'll have several syndrome-specific breakout sessions that you can go in and essentially hear a recap of a recap of the meeting and be able to ask questions directly of some of the researchers, some of the doctors that you may already know, Dr. Gelb, Dr. Grip, Dr. Rowan, Dr. Korf. So, so that'll be on the last day. We're hoping that we can have complimentary registration for families, but we'll definitely keep you posted on our social media accounts and on the website as to when that's going to be opening. And we miss all of you guys, and we hope to be able to see you in person for our next symposium, but please stay tuned and plan to attend the virtual meeting in July. And that's a wrap for us.
So thank you everyone again for coming. We appreciate you. Actually, I'll unmute Lisa Scheuer as well. We appreciate it. And if you ever have any questions, please, reach out to us via email. There we go. I think I unmuted you. Yeah.
Thank you all very much for coming. And I have a lot to take to the Costello families after this conversation.
All right. Have a great evening, everyone. Thank you. And I guess I should say, does anyone else have any questions before we go? You can just throw them in the chat. Oh, wait, there's 2 chats. Oh, just thank you. And reach out to us too if there's any other topics that you'd like to hear from. We're going to try to start having these conversations more often. So if there are other researchers or other topics that you want to know more about, send us an email.
Good to see everybody.
Bye.